The job creators and key people in key industries here in the district, and I wanted to hear from them to the extent I could at the same time, so we have more of a conversation, not with me, but between them. We certainly have packed these panels, and it is a challenge to get everybody worked in, but I think we did a pretty good job the last hour and a half, and so that's why we're making sure we stay on time. You know, healthcare differs. That's all this panel is going to talk about. The other one dealt with 3 different issues, industries, and the other panels in the rest of the day will as well. Healthcare is unique because certainly we are interested in healthcare jobs, like we are interested in energy industry jobs and agriculture industry jobs. We're certainly interested in that. But healthcare goes far beyond that in 2 ways that the other industries don't. And the first way that healthcare is different is all employers are impacted by healthcare. We're not just talking about the healthcare industry workers. If you have a manufacturing business, if you have an energy business, whatever your business, healthcare matters to you. So the broad subject of healthcare is important to all job creators in a way that some of these other issues are not. And then second way that it's different is that healthcare has to be addressed if we're going to address our broader national debt problem, because we have not only rising healthcare costs, but the big drivers of our debt in terms, and a lot of it's due to demographics, are Medicare and Medicaid. And so if we are going to deal with the broader issues that the country is facing, separate from the jobs issue, we have to deal with healthcare, particularly as it relates to debt. What I'd like to do is we'll just start alphabetically over here. The folks are arranged, and just let them introduce themselves and where they work and what they do there. And then I'll throw out some topics and just try to steer the conversation, but basically want to keep this as casual as possible. As I told the audience with the first panel, if you have a question, we have some cards over here at the table. Just raise your hand, and John will bring you, or Brooke will bring you a card, and you can write the question down, and they'll bring it to me. And if it is something that has not been addressed, then I will work to incorporate it into the conversation. So if you'd like to start, we'll just go right around, and then we'll get started.
Thanks. I'm David Berry. I'm the Chief Operating Officer at Arkansas Children's Hospital.
And I'm Sue Ganaka, and I have 10 IHOP restaurants here in the state of Arkansas.
I'm Carrie Helm. I'm the CEO for Arkansas Surgical Hospital.
I'm Tom Kane. I work with Stevens Insurance. I'm an employee benefit consultant working with employers.
Cal Kellogg, Senior Vice President, Arkansas Blue Cross Blue Shield.
Mark Lohman, Vice President, Strategic Development, Baptist Health.
Linda McIntosh, an advanced practice nurse with Sherwood Urgent Care in Des Arc, Arkansas.
Sip Mountain, representing Community Health Centers of Arkansas. There are 73 locations in your state.
Good morning. My name is Derek Paul, Vice President and Chief People Officer with St. Vincent Health System.
I'm Dan Ryan. I'm Chancellor at UAMS.
And John Robbins. I'm the CEO and President of DataPath, Inc.
My name is Mike Stock. I'm the President and CEO of Qual Choice Holdings.
I'm Joe Thompson, the Director of the Arkansas Center for Health Improvement, and serve as the Surgeon General for Governor McDeevy.
I'm Randy Wyatt with Senior Living Communities. I'm Vice President of Public Affairs.
What I'd like to do is start by identifying some of the problems that a lot of you have discussed with me more than once, and that is, and this won't impact everybody equally, but I'd like for some of y'all to talk about what the federal budget mess, what impact the federal budget mess, and more specifically, what impact the debt and the deficit commission and the CRs and cutting spending, what impact that has had on your organization, whether it be UAMS or Baptist or whoever wants to speak on this. You want to start? I know this is something we've talked about before.
I made the cardinal mistake of serving on panels. I made eye contact with the moderator. So I think it's fair to say that at the federal level, issues under discussion are what are impacting us most significantly, rather than what has been implemented. The potential reductions in program support at well, let me begin. UAMS, of course, is comprised of our colleges, institutes, area health education centers, and the health system. 9% of our budget comes from state appropriation, 2% from tuition, about 15% from research grants and contracts, the majority of which is federal, National Institute of Health, and about 75%, 73% I think it is, from clinical revenue, and then the balance is philanthropy, 4 to 5%. We're intensely dependent on clinical revenue to support our academic programs and our research programs. Our patient mix, at the present time, 13% are uninsured. That has increased from a historical level of about 10.5%. About 30% are Medicare, because we don't have children, except for in our nursery, 19 to 20% are Medicaid, and the balance are commercially insured. Proposals that affect Medicare funding or Medicaid funding have a profound impact on the clinical revenue, which is the bulk of the dollars that support the institution. Proposals under consideration involve, of course, reduction in physician fees for Medicare, as much as 30%, SGR issue. MedPAC proposals involve other reductions. Graduate medical education proposed reductions through the President's bipartisan commission and currently still being considered involve reductions in support for the two major fund streams for residency education. They're called indirect and direct medical education. And then, so if you add together the physician and hospital reductions that are under discussion, it would amount to close to $20 million a year annualized at UAMS. On the research side, the bulk of our funding, as I said, comes from federal research grants and contracts. Other reductions to the Health and Human Service budget that would affect funding to the NIH have a potential of significantly affecting research grants and our ability to sustain our research enterprise. The continuing resolution right now involves a continued payment structure at 90% of original award dates. So we're currently operating with 10% less than award amounts. When that is combined with the state strategy to manage Medicaid costs and the need to reduce that, we're really looking at significant threats to the business model that supports the state's only academic medical center.
Have you put these cuts and the impact, potential cuts and the impact in terms of jobs? How many jobs do you think we're talking about in terms of job losses or inability to hire more?
Well, we've already, we have a reduction right now of about 350 positions in comparison with when I began as chancellor on November 1st of 2009. And that is principally in our clinical area, and that has been in order to manage cost, cost issues to date. The increased uninsured volume we're seeing is increased workload with no new revenue, and so that is putting pressure on the budget right now. We're essentially breaking even, but we're not generating revenue for strategic investments in the future. If we were to experience, for instance, reductions in graduate medical education funding, we would either have to eliminate residency positions, which would exacerbate existing and projected physician shortages, or we would have to eliminate other positions or programs in order to continue the residency positions without that funding. When one looks kind of across the entire enterprise, in the clinical system, we have kind of an average cost per position of $50,000 to $60,000 when one includes nursing and benefits and all of that. So you can just kind of run the math of what the personnel impact would be.
This is a good place, I think, to start the conversation because unlike some of the other industries we heard from on the first panel who said this regulation or that regulation or this change in the law is hurting us or holding us back or needs to be made, I don't want to put words in your mouth, but it sounds like from our past conversations and what you've said here today that your biggest issue is to make sure the federal funding stream for some of these critical programs is maintained. Is that fair to say?
Well, yes, I think at a policy level, of course, I'm an advocate for support of
Sure.
health professions education.
Sure.
I think that's critically important, as well as biomedical research.
Sure.
So that needs to be maintained. But we've got an institution with a highly leveraged business model, and we know that healthcare costs are unacceptable going forward and the rise of healthcare costs. So we've got to have the ability to make adjustments in a framework where we know what the policy plan is, and it takes time to make those adjustments.
That, it sounds like, is similar to what we heard on the first panel, which is change is not necessarily what you're concerned about. It's the aggressiveness and the suddenness and the inability to have time over a reasonable period to change your model or adjust to the new reality. It sounds like that's part of what you're saying. Dr. Thompson, do you want to talk about some of the funding problems that you see?
Well, and let me even back up one step. I appreciate this panel. Thank you for pulling us together and for your leadership and representation in Washington. Health and health care nationally is about 17% of the gross domestic product, and it's probably over 20% in this state because we have a sicker population on average than most states. So I think it's a critically important economic issue to manage and population asset that we need to be pretty aggressive in supporting. Our healthcare costs within this state and nationally have been escalating over the last 3 decades far faster than our increase in gross domestic product or any other revenue side statistic. It affects large and small employers. It outstrips their ability to continue to offer health insurance coverage. And yet, we still morally and ethically believe we should treat everyone when they need care. And that's the juxtaposition we put ourselves in. And part of the thing the state is doing, we're leading a payment reform effort that Dr. Ron mentioned, where we are intentionally trying to move away from a volume-based, provider-centric, fee-for-service payment model where the financing is to do more things to generate more funds, and that's driving on the escalation of healthcare, to a patient-centered, coordinated effort that really tries to address some of the escalating costs. It is change. There's nobody that is comfortable right now with the amount of change we have in our healthcare system. That's, again, 20% of our state gross domestic product, my estimate. Employers, families, businesses, physicians, hospitals, everybody is anxious. But I think it's a change that we have to go through because the previous system was unsustainable. I mean, we're facing a $200 million shortfall on the Medicaid budget year after next, state money. We get a good match 3-to-1 with federal funds, so that's $1 billion. That's 1/4 of our state Medicaid budget is not funded 2 years from now. And if we don't go through this change, the alternative that we're looking at is actually eliminating prescription drugs from the Medicaid program. And I think it's important to note over half the pregnancies and half the kids are covered by the RKIDS program. We would be taking that program down in the next 2 years if we don't find a different path through this very dicey economic situation.
Now, if I could ask, so obviously the funding aspect impacts what you're doing and is a big reason for what you're doing in terms of the Medicaid reform. Let me ask you this. There's no doubt that all various parts of our healthcare system have been on unsustainable paths for a long time, whether you're talking about Medicare, Medicaid, or the rate of rising costs. To what extent is the reforms that you are working on in Medicaid, to what extent are those reforms flowing out of the national change with the Affordable Care Act, or are they just changes that had the Affordable Care Act never been passed, you would have had to make anyway?
Sure. We have 4 different activities, 3 of which are independent of the Affordable Care Act, and let me just very briefly share those. One is a effort that was actually brought about by the Stimulus Act to get our doctors and hospitals on electronic health records and to have people connected. We are still operating in a 20th century mode using paper records, and where people don't have the information available when they go to the specialist that the primary care doctor had, or the x-ray is not there and we do more x-rays, and that's part of the contribution is we need to get on an electronic system. So that's the first effort. The second effort is one that's led by Dr. Ron and Dr. Halverson on a workforce strategic plan, and I would just say that the jobs of the future, not necessarily knowing where the funds are going to be, but the jobs that we are going to need are support jobs for that electronic record system. Most doc's offices right now don't have anybody who could help manage a server system or a network. So electronic support jobs and also care coordination jobs, so that we leverage the licensed medical professionals we have to make them more efficient, more effective, more available. The third area that we are doing as a state independent of the Affordable Care Act is the payment reform effort that you mentioned, where we are with the private sector, Blue Cross, Qual Choice, United, and the Medicaid program. We've asked Medicare to join, and we may need your help with the Secretary to push a little bit to get Medicare in the tent with us. We want to move away from a volume-based fee-for-service system to one that actually rewards providers for getting good outcomes for the patient, not how many procedures or how many visits or how many hospital days they ended up providing. And that causes some tension on the system, because that's the business model. It's been a volume-based business model. We're trying to move it to an outcomes-based business model. So those 3 are state-specific: electronic records, workforce, payment reform. Those are all under our control, stimulated by our needs. We would be doing it whether there was an Affordable Care Act or not. The fourth on the Affordable Care Act, and I think this is an issue of obvious not uniform agreement, but we have in our state of 2.7 million citizens, about 500,000, mostly working Arkansans, that have no insurance coverage whatsoever. As we have lost higher paying manufacturing jobs, we've actually had more people join. We've had the economic downturn of the last 3 years. We've had fewer employers being able to offer insurance. We've had more people joining those uninsured roles. And so what we're trying to manage are the opportunities, the positive opportunities that the Affordable Care Act offers, and avoid the negative consequences that could come along with it too. So it is the federal law. We're trying to get positioned to take advantage of it. From my perspective, our state is a poor state. Our median family income is about $45,000 a year compared to Maryland, where it's $85,000 a year. We're never going to get federal money for a high-speed rail through Arkansas. We ought to grab all the dollars we can to get insurance coverage for our folks.
Let me ask, I want to continue to pursue this issue of federal funding, just so we have a good idea of what the impact of the budgetary squeeze is. Obviously, it's impacting the state, UAMS. Others here want to talk about that. Yeah, sure.
At Baptist Health, we know that over half of our budget is fringe benefits and salaries, and we're the 3rd largest private employer in the state. We know health care reform, the Affordable Care Act, will probably cause us to create jobs. The stimulus bill will probably cause us to create jobs, to hit meaningful use. Now, in and of itself, that's a good thing. But we also know that at the national level, health care reform took $155 billion out of Medicare Part A over 10 years. At Baptist Health, that's $138 million over 10 years. We know that if sequestration were to occur at the end of the year, that's a 2% cut, an additional 2% cut, which is about $43 billion out of hospitals nationally. For Baptist Health, about $8 million. So coupled with putting more people on and taking less revenue from our main payer source, which is Medicare, that's a bad mix. And our biggest fear, quite frankly, Congressman, is that there are things done that thwarts adding people who have no coverage to health care, yet we still get the cuts. And so complete repeal of health care reform and keeping the cuts is not a sustainable solution for us. And quite frankly, the 2% sequestration is starting to look like the best deal hospitals are going to get. And it pits us against the defense industry, you know, an equal cut there. Anything other than sequestration probably will have more severe cuts to Medicare. So from the state's, one of the state's largest hospitals, it appears Medicare has become the cash cow for deficit reduction. And we think that's an untenable thing long term, and it certainly doesn't drive down 17% of the gross domestic product that has to happen to get cost under control.
Yes.
I just wanted to add from a private payer's perspective, you have to recognize this is a system. And so when you start having the federal programs cut back, then the hospitals and providers have to look to other sources to try to cover their costs and maintain their operations. And then that becomes part of the negotiation process for us when we sit down at the table to negotiate rates and payments with those folks. That then it tends to shift the cost more to private insurance, which then in turn shifts the cost to employers, and then employers have to start looking at, well, do I reduce benefits? Do I increase the amount of cost sharing that my employees have? Do I completely drop the benefits and so forth? So we have to recognize this is an integrated system, and when you pull on one part of it, you're pushing on another, and I think we've got all, and that's part of the reason it's important to get to these cooperative discussions about how do you reform payment systems and so forth, so that you can deal with it as a bundle, because this is not something that you can cut pieces out of and solve the issue. You've got to really sit down and deal with a very big issue that's very messy, but it takes time. But if people have a good dialogue, I think you can get to those solutions.
What's interesting is, as I think about what Dr. Ron has said and what the others have said, is I think about the federal budget, and it's two components: mandatory spending and discretionary spending. Some of you are most concerned about funds that come out of the mandatory side, Medicaid, Medicare. You you're concerned about both, because a lot of what you've talked about is from the discretionary spending side, NIH funding. I think the funding for the graduate slots and what have you. And so you're impacted by both sides of the squeeze. And is there anyone else that wants to weigh in? Yes, sir, weigh in on this.
I just thought I'd make an additional comment. Everything Dr. Rand said is exactly true about children's, with the exception that where they're heavily Medicare, we're more than 60% Medicaid. When Medicaid gets a sniffle, we get pneumonia, and we watch it very carefully. Part of our challenges in the coming days is really just being uncertain about what's about to happen. We're sort of doing constant scenario planning, trying to figure out what does a 10% reduction in Medicaid look like, and how would we adapt to that, and how many losses, how many jobs would be on the line. Like my colleagues from Baptist, the majority of our budget is on salaries and benefits. And when you significantly impact Medicaid funding, it means jobs, and it means lots of jobs, and it means lots of jobs in a hurry, because we can't drop the responsibility we have for caring for Arkansas's kids. The second thing around graduate medical education I'd touch on, and children's hospitals are a little bit different. Their graduate medical education has typically been tied to Medicare. In the last few years, there have been bills enacted called Children's Hospital Graduate Medical Education tied to Medicaid. That went away in the budget, last budget proposals. It's on its way back, and we appreciate the House's vote to restore that to the mix. Still waiting on Senate action. But that's really critical to us in our ability to train pediatricians for the future. We talk about taking care of people. We talk about developing ways to care for everybody that needs coverage. If we don't have physicians, we don't have general pediatricians, who, by the way, mostly stay in our state, don't enter specialties, they become primary care providers in our state. If we don't have the funds to do those, like Dr. Ron, we end up having to consider, how do we eliminate those positions? How do we come up with those losses and yet continue our mission of providing those practitioners to care for the children of our state? It's a great challenge, and it's one that has sort of been dealt with in a way that we're appreciative it's coming back, but one that sort of also sent us reeling very quickly of how do you respond to that sort of a loss of federal funding.
I want to, anyone else want to jump in real quickly? Then I want to put up a couple of charts and get your opinion on. Go ahead.
Congressman, with your permission, you asked earlier how we would be impacted, and the community health center is a little bit different model than the private practitioner out in the communities. We'll be impacted by what's happening, whether it's on the discretionary side or whether it is on the mandatory side, because of the health center trust fund that's in there. And I think all of you guys would agree that with the continuum of care, there's absolutely critical need for prevention and primary care, so that we can ensure that those patients that are going to end up in your hospitals or are going to be funded with Blue Cross Blue Shield or Qual Choice or whatever, we want to make sure that we take care of the expenses on the front end with primary and preventative care. And so what's happening right now on a national level is definitely going to impact our unique opportunity as a community health center through discretionary and mandatory funding, but it's also going to affect the private practitioner in the primary and preventive care as well. And so we're watching that very closely, as your office well knows. We've got 500,000 people in this state today that don't have a healthcare home. And with our state's initiative of moving towards patient-centered medical home, we've got to make sure that the funding is available for primary and preventative care, so that when patients do get on the continuum and move to secondary and tertiary care, we have taken care of it, so the really sick are the ones that are there, and we can take care of the issues on the front end. So we're watching and monitoring that very closely.
And we, thank you for that, Sip. We have talked a lot about investing in the early treatment of diabetes or obesity or high blood pressure or whatever, so that you can, A, give the person a better quality of life, but B, avoid a lot of the catastrophic stuff that cost a whole lot more down the road. And community health centers certainly provide that in rural, particularly in rural areas where there are no other providers often, no hospitals, what have you. I want to get into, in a little bit, a couple things. I'll just tell you so you know what I'd really like to cover. I do want to talk about the impacts of the Affordable Care Act, particularly on businesses that are represented here, and the challenges with that. I want to talk about some of our options to try to reduce costs, whether it be between, whether it be with market forces, whether it be with tort reform, whether it be with competition across state lines. I'm sure you'll have something to say about that in the insurance industry, wellness programs. I want to get to that, but while we're on, since Medicare and Medicaid are right up front here and are important to a lot of the people, I want to just show a few, just a couple of slides here, if I can get this thing to work. First, I want to show this chart, which this is the 2010 federal budget. And it's not up to date completely because it's 2010, but I think it's a good representation still of pretty much where we are. This spending over here, the red and the green, that's discretionary spending. So when Dr. Ron talks about NIH funding or what have you, that's non-defense discretionary, that's in here. As you can see, this is most of mandatory spending is, I think it's fair to say that most, or close to most, is healthcare related. Medicare, Medicaid, there's some stuff in the other mandatory that relates to veterans, healthcare. big slice of it is interest on the debt, $200 billion a year, which is money I wish if we had that money to spend elsewhere, this panel would go away because we'd have the money we need. In any event, right now, the mandatory side of things is, and if anybody disagrees with any of my characterizations, please let me know. These are CBO budget numbers. But this is about mandatory spending is about a little more than 60% of the federal budget. And discretionary is the other part, 38%, whatever. Okay. Now, the trend is what, and I have that as another slide, but I think it's way down the list, so I won't show you. The trend is one that hurts Dr. Ron because the mandatory side, if you view this as Pac-Man, this is the mouth. This part of Pac-Man's mouth is closing. And the squeeze that we have on the discretionary spending is because of the growth of mandatory spending. About 30 years ago, mandatory spending was 20% of the budget. About 20 years ago, it was 40% of the budget. Now it is 60% of the budget, okay? That's not because Congress is going in and just raising it every year, okay? The thing with mandatory spending is it's in the law. Congress, and you may like this, could go on vacation for 20 years, and mandatory spending would just keep on trucking because it's automatic. We call it autopilot spending because it does not have to be approved year to year. It's in the law. So the trend here is that we're at 60% of the budget now, and the mandatory is going to 80, and then in 2050, it will be 100, which means the $1 trillion that we spend now on the discretionary side is just a little over $1 trillion. All of that would go away under that scenario. No Department of Labor, no Department of Transportation, no Health and Human Services except for the Medicare, Medicaid, no Defense Department, nothing. Completely gone. The government as you know it would cease to exist. So my point is the mandatory side is growing, and in order to help get our fiscal house in order, it's putting immense pressure on the discretionary side where a lot of Dr. Ron's, a lot of the programs that he talked about are. And so for folks that are dependent in SIP, who are dependent on both sides, there's pressure on both sides. And the interesting thing is you could eliminate all the discretionary and we still would be in the red for the year because we have a $1.6 trillion deficit. So I just throw that up there, and then I want to get your comment. This is about 2050, where the entire, that dot right there is where the entire federal budget is Medicare, Medicaid, Social Security. We're back here somewhere now, and you can see this wide area is discretionary shrinking. Okay, and then I want to show you a couple of quotes. This is Senator Obama's quote on Medicare this summer. If you look at the numbers, Medicare in particular will run out of money, and we will not be able to sustain that program no matter how much taxes go up. I mean, it's not an option for us to just sit by and do nothing. And then Senator Lieberman, quote, "The truth is that we cannot save Medicare as we know it. We can save Medicare only if we change it." Now, discuss. And so on the Medicare issue, I totally agree about the impact of the cuts. What the next question becomes, what are our solutions that don't just deal with the cuts or increases, that structurally, how do we structurally change? And you're doing this on the Medicaid side, and a lot of states, I know Rhode Island has done some stuff on the Medicaid side, But taking Medicare for a minute, I'd love to hear some thoughts on how we structurally change some of the aspects of Medicare so that the cost curve can be reduced, we get more for our money. Because I agree with you, cutting alone will not solve the problem unless you basically cut to a point where the program is non-existent. Because the demographics of the baby boomers going from paying in and being, in their 40s and 50s, whatever, to the other side where they're starting to benefit from Medicare, that is, as you know, the demographic thing is the challenge. So I want to hear your thoughts on Medicare. Yes?
One of the things that we have to look at as an industry is we can't rely on the old methods of what we have done before. We have to look at new, innovative methods to do that. And when we think about the growing Medicare population, we look at how did they spend prior to obtaining Medicare and how do they spend after they receive Medicare benefits. And as all of us, as we have high deductibles and co-insurance and co-pays, we look at that a lot differently. And we make choices a lot wiser. And we take the health choices that we're making to a higher level than if we're receiving something with minimum co-insurances and deductibles or no responsibility for that payment. And I think we've tried to shift the responsibility to physicians and providers. And really, it's personal accountability for the healthy choices that you make. A physician or a provider cannot control obesity, diabetes, high blood pressure, and cholesterol in this country. We absolutely cannot. We can provide mechanisms to control it. We can provide programs to assist in attaining it, but we cannot make the healthy choice for the individual to do it. And unless we find programs and we're innovative in how we develop those programs to shift the responsibility from someone other than the individual, we will not make progress in controlling costs.
Yeah.
So, sorry, go ahead.
I just would like to kind of reinforce that. I mean, I think, Congressman, we have to have clarity of thought about what we're talking about and what the issue is. So when Dr. Thompson mentions that, I think you used the expression, Arkansas is an unhealthy state. When you look at what lies behind that, most of the issues are issues involving nutrition, exercise, diabetes, the occurrence of diabetes as a consequence of obesity. These are issues that are outside the traditional domain of healthcare practice until the consequences already occur. So we got to focus on that issue, number one. When we say we're unhealthy, what are the potential strategies to become healthier? Another issue is this issue of cost, and we need to be honest about this, I believe, that if we were to bring Medicare cost increases on a per enrollee basis into line with economic growth, it wouldn't solve the problem, because the number of enrollees in Medicare, as currently structured, is expected to double over the next 18 years. So, we got to focus on what that issue is as well. If it's Medicare cost growth, we need to not only deal with the per enrollee cost, but the total societal cost, given that the number of enrollees is going to go up on a proportional basis so dramatically because of us moving through. So we're absolutely going to have some programmatic changes, some changes in payment structure to get the cost per enrollee down. But then as providers, we're going to have to be part of the process so that we can construct business models that enable us to have a revenue stream that still is above our cost so that we can cover our costs, right, and still meet the societal mission that we have. We really need to approach this with everybody engaged. It's not, we don't want to be, none of us wants to be an enemy to change. but we've got to be part of that process in order to craft solutions that are going to enable us to continue to do what we need to do for the benefit of society.
I agree with that. I'll say this. If you're talking about the different things that will save money, that will reduce cost in the healthcare industry, that applies writ large, whether you're talking about Medicare, Medicaid, healthcare generally. And I want to get into that here in a second. But if we could focus on something you said, Dr. Ron, structural changes to Medicare. I want to hear y'all's thoughts. What are we talking about? If we agree with some of the statements that we see up here, that something has to be done as a result of the demographics, if for no other reason, where we get more out of the dollars that are being spent. Yes, sir.
Well, I think it's more basic than just people taking responsibility for being healthier and we want to change the system. The basic economic model of how healthcare is purchased in this country doesn't work, and it's not sustainable. You know, a lot of what came out of the Accountable Care Act was to make healthcare more accessible to more people, because there's an argument and debate in the country about, is healthcare a right or a privilege? Some people believe it's a right and everyone should have access to as much of it as they need. Well, the problem with that is when someone else is paying for it, then people will use as much as they feel like using. Whether healthcare is a right or a privilege, we can debate, but take something as basic as food. There's no more basic necessity than food. But yet we don't have the inflationary problems in the food service industry that we have in the healthcare industry. And that's because everyone uses their own economic resources to provide for themselves in buying food. When you have an economic model where A buys from B and it's financed by C, A will use whatever they want to use. And until that economic model is altered, you're not going to control the inflationary spiral that exists in the healthcare industry.
Anybody? Yes, sir.
I don't want to discredit any of the information that we're talking about on the economic side. But in your earlier panel, you talked about something that impacts healthcare, and you want to know how to change that, and it has to do with regulation. You said something about regulation. Dr. Thompson mentioned patient-centered care. Other people have too. To applaud Arkansas, the Department of Human Services has done an outstanding job of applying the regulatory process in our setting, long-term care and post-acute care providers, in a very fair and publicly based service way. I mean, there's no room for zero tolerance. I mean, there's no room for mistakes. We are cited for negative outcomes, and they do a very fair and equitable job of that. But on a national level, to fix Medicare, you're going to have to address I hate to use the word arbitrary, but you're going to have to address the frontline decisions that are made at CMS on a regulatory process, whether it affects nursing homes, whether it affects physicians, whether it affects hospitals, whether it affects health centers, whatever, because they are made in a closed room, non-participatory environment, in my opinion. And Dr. Thompson's comment about pay for performance, basically, or patient-centered care, is an open book in the long-term care community. Our company, our 16 skilled nursing facilities are already moving towards electronic health records. We're using that. We use kiosks in the facility to monitor all the activities of our residents on a daily basis. But you can't just fix it economically. You've got to fix it as a whole. And I mean, just my opinion.
So I think that some of the things that we talked about on the regulatory side in the earlier panel would apply here, and that is Regulations are only drafted and proposed by agencies pursuant to congressional authorization. But the way the process is now, once Congress authorizes regulations, they lose complete control, except for being able to comment, over the process. What we have proposed with the REINS Act, with high dollar impact, high impact regulations, there would be a new requirement put on at the end that would require them to the agencies to come back to Congress and say, is this what you meant? And so there would be elected people, elected officials involved in the process, because once it gets to the agency, as well-meaning or whatever as folks are, they're not elected. The folks writing those aren't elected by you, and you probably don't have their cell phone the way you do mine. And they probably wouldn't answer if you called. But, and so that, we're looking to make some changes on the regulatory side. What I am hearing here is, going back to what you said, Michael, is the whole and what y'all said is skin in the game. That folks have got to have skin in the game. And I hear that all the time. I was talking to some folks yesterday who said that they have gone to a system where their employees have to pay up to $3,000 or $3,000 per individual, I think $6,000 per family before anything is covered by insurance, to really give them skin in the game to take care of themselves and what have you. And so for a lot of them, a lot of the employees never get to the insurance on a year-to-year basis because they're paying out of pocket. I'd like to hear more about the skin in the game, because it sounds like that's, yeah.
I think that's right. What we've heard a few times today so far is that we need to have the user of the healthcare and more involved in the process. And at DataPath, we specialize in consumer-directed healthcare accounts and administering those accounts locally and on a national level. And the plan that you just described, where we have a $6,000 deductible for a family, is becoming much more common. And typically what happens, one of the concerns that exist when an employer goes to offer those plans is that the employees are unable to fund that potential out-of-pocket exposure. And so consumer-driven healthcare accounts are a way to help ease that financing burden for those employees. So a health savings account, flexible spending account, health reimbursement arrangement, various types of accounts that funds could flow into because of the reduction in the insurance premium that the employer pays, or the election of additional amounts that an employee may put in there. And then they can have that skin in the game. They can have those savings set aside, and then they can be a little more careful, I guess, about how they spend their healthcare dollars, be more efficient in how they spend their dollars. Now, there's additional tools they'll need to help them with that process. They need to be engaged with wellness. They need disease management help. They need the ability to know which healthcare providers or quality healthcare providers have the best outcomes, for instance. But allowing individuals to have access to those funds and be involved with the process of purchasing healthcare will go a long way to change the way the whole country looks at healthcare. And maybe eventually, as Carrie was pointing out, that it'll shift how they all spend, and that may have an impact in the long term for Medicare.
And again, the things we're talking about here apply writ large to Medicare, Medicaid, the healthcare industry. Michael, going back to your point, what specific changes are you talking about? You're talking about it sounds like you're talking about a national change out of Congress to restructure the way the forces within the healthcare industry work. Is that what you're?
Well, I mean, there are a lot of pretty drastic things that you could do. I mean, the tax code is set up today to favor corporations financing healthcare, but not to favor individuals financing their own healthcare. Should it be that way or not? I mean, we know that the tax code was structured that way because of the issues that existed back in World War II with wage and price controls. and so forth that led to those provisions in the tax code. One of the things you talk about having more skin in the game. One of the things that we understand, I've heard, is on the table to be discussed by the super committee that's going to solve our budget problems.
Don't bet on it.
One of the products that we sell and that Blue Cross Blue Shield sells is Medicare supplemental insurance. There's discussion that the super committee wants to look at controlling that product and limiting its ability to do what it does. I mean, seniors buy that product to cover those costs that the Medicare program doesn't cover for them today. But the government doesn't like that, because then it means that people don't have as much skin in the game because insurance is paying all the costs. So they're talking about controlling and moderating and cutting back what Medicare supplemental policies can do, so that people have to take more money out of their own pocket. So they're trying to eliminate that a little bit. The provisions that come out of the Accountable Care Act, again, are designed to eliminate skin in the game that people have. Some of the most basic things that people should do to take care of themselves: do preventive care. Well, consumers will no longer have to pay anything for preventive care. The insurance companies will pay for it 100%. You're no longer allowed to have any cost sharing. So the benefit plan that you mentioned that your friend has, where the people pay the first $3,000 out of their pocket, except for preventive care, because that'll be free now. And starting next year, all birth control will be free. So we're eliminating skin in the game for people and making things more, there are a lot of very positive things that come out of preventive care. Don't get me wrong. But when somebody else pays for it, people don't worry about doing the things that are necessary to take care of yourself and remain healthy, because when you get sick, somebody else is going to take care of it.
Anybody else want to comment on that? Yeah.
I want to thank you for inviting me to share the perspective of a small business owner and how healthcare will indeed impact.
Thank you.
How the proposed healthcare plan will indeed impact us and possibly even put us out of business. Here in the state, we employ at this time just about 500 people. And our turnover alone is so great that this year we've experienced about 165%, which means I've turned over 800 people. So not only would I be held accountable for paying for health care, but administratively I would have to keep up with all of those people. Now, people might say, well, if you offered health care, maybe you can retain more employees. But that's just really not part of our reality in the restaurant business. Restaurant business is very transient. It's a temporary position for a lot of people. I wish I could supply health care and provide it for everyone. Actually, right now at this time, we do use it as an incentive for people to become a member of our management team. It is one benefit that I can offer, which is full health care benefits, along with dental, eye care, vision, life insurance. If you take that away from me, I have no incentive to ask people to take on the additional responsibility that I need for them to provide me to run my business. So it's taken away a very valuable tool for me as well. We've done all the numbers and the math. Even though I employ over 500 people, our revenue is under 20 million. It's maybe about 16 million a year. So if you figure out how much health care would cost, if I was even responsible paying the penalties, which is about $2,000, I believe, per person that is considered full-time, that will put me out of business. And that will close all my doors, my restaurants, utility companies I support, the maintenance people I support, my employees' jobs, everything that goes along with running and generating the revenue for the state. So all those realities are just, we're in a state of fear.
Yeah, go ahead.
At Stevens, we work with several hundred employers, and we hear the same story from many of them. And you talk about uncertainty. When we're dealing with our clients today and trying to advise them to develop forward-looking strategies, it's impossible, because we don't know what the Affordable Care Act will look like in 2014 today. Now, we're going under the assumption that it's going to remain law, but we're not sure. To give you an example, yesterday, today, and I believe the rest of this week, Health and Human Services is holding closed-door meetings with consumer advocacy groups to develop the essential benefits package. And basically, that will define what Blue Cross, Qual Choice, every health insurance company will have to provide in order to be in the health exchange. Our concern is that that is going to be a much expanded benefit package, and that will be very inflationary. So employers and individuals alike, when they go to the exchange, what they're going to see is going to be very expensive, and it's going to be much more expanded. You know, a common sense approach would be to provide people with the choice to buy a bare bones major medical type policy where they have more skin in the game, or if they as a consumer choose to, in a free market, to buy a richer plan. But for the federal government to legislate to us, it has to be at this level or you can't play, I think it's going to be a real problem.
Can you comment on, I know we had talked before on the federal government's, with them suing some companies over wellness plans, and what's the, because it sounds like to me that most of us agree wellness, I think all of us agree, wellness is a good thing. Wellness will help prevent future catastrophic cost. We should be encouraging wellness and good, healthy behavior. Some companies are giving discounts for sustained, healthy checkups and what have you. Can you comment on that? I know you and I talked about the federal government suing some companies because they were giving certain employees breaks for healthy behavior.
What we talked about was the EEOC and confusion in the different agencies and what an employer can and cannot do. What we have found, and unfortunately, people will not choose healthy lifestyles unless you put a significant financial incentive or disincentive. Many employers are looking at implementing premium differentials. And so if an employee chooses to participate in the program and they hit certain benchmarks, they pay a lower premium. I mean, it's just like car insurance today. If you're a safe driver, you pay lower car insurance premiums. What we need from the federal government is a crystal clear set of rules and guidelines. What can an employer do? What can they not do? We don't need employers sitting on the sidelines saying, I want to do this, but I'm afraid if I do, I'm going to end up in court being sued. And we saw that happen in Broward County, Florida, where some former employees of Broward County sued and were classified as a class action. Fortunately, it was not upheld. But that's just Congressman's crystal clear rules and guidelines.
Could you speak to that as well?
Yeah, I would like to kind of reinforce that same thing because we see a lot of conflict in the regulations and so forth. But just to give you an example, we're wanting to try to do the same sort of thing with our own employee base, and but we have to, and we want to try to maintain our grandfathered status under the infamous "if you like what you have, you can keep it" aspect. And we found that in order to try to keep our grandfathered status in place, we could only change the premium differential a very small amount in order to maintain grandfathered status. Yet, and it's probably not going to be enough to behaviorally affect some of our employees to engage in the health risk appraisals and engaging in improving their behaviors and the things that we should be doing as individuals and as employees of a company to try to control the costs and so forth. So even within the Affordable Care Act, there are conflicting regulations there that get in the way, and how the regulations are structured, get in the way of employers being able to do some of the things they need to do to address some of the issues that would structurally help improve the overall cost of care.
Is there anybody else that wants to comment on that? Because that's something that we can actually, I think, get together and try to impact the agency on.
Well, one of the things that we do at St. Vincent, one of the things that we're doing at St. Vincent's is more of a culture of wellness, because not only are we a healthcare provider, we are employers as well. And one of the focuses that we have is wellness, and it's been a gradual integration process where we are shifting from flat rate copays, because we found out that part of St. Vincent's, let me just back up for a second, is we're part of Catholic Health Initiatives, about the third largest not-for-profit health system. We have about 68,000 employees across the country. So when we started out 3 years ago, they did an assessment based upon utilization and claims, and our employee population at St. Vincent was the least healthiest of all of the MBOs in the 20 states that we have, the 68,000. We knew that with our year-over-year increases being 9 to 11%, we could not sustain that momentum. We shifted to more of a wellness, where we went from co-pays, where when the employees went to the physician, they just said, let's order any and all tests, that sounds good, to more of a co-insurance. So we're making them more of a healthcare consumer to be informed about the choices that they make and the costs that are associated with that. That was one phase to start to change the behaviors. We implemented a personal health assessment where our employees went through a personal health assessment to come up with the part. We had no action if they took no action, but we said if you do it, we'll give you a discount over your premium spread out over the year. We had about 53% of our employees participated in that first year. The second year that we went through the process, we went to biometric screenings where we took blood work, we went through the whole process to determine the health status of our employees. Based upon that, we had health coaches that were assigned to employees to help work with those issues that were identified. And as a result of that, we had a lot of employees start modifying their behaviors. We also knew, because it was life, in some cases, based upon their assessments, because some of our employees were never going to the doctor, they were never doing these things here, and it was a emotionally charged event when they realized that their cholesterol level was really high, their blood pressure was really high. It forced them or compelled them to do things. So with the health coaches, we worked with that. The other thing that we did, we started offering wellness programs that was free. And one of the times we opened our gym, and this would be it was strange, and we made our employee gym free. And we saw the utilization of the gym decrease when it was free to the employee, but when we had a slight cost, people said, I'm vested, I'm paying $5 or $10 a pay period. I'm going to use it now because I feel that I have skin in the game. But I say all of that for the efforts that we're doing with our employees. We went from being the least healthiest, now over the 3 years, we're close to the top because our employees changed from the co-insurance. People started asking questions. Why am I having this test? Is there another alternative to have this test in the process? And the last thing that I will say is we realize that as an employer, throughout the system, CHI as a whole, we had about 6% of our employees that could not even afford our insurance that we were offering. So we are providing subsidies to some of our employees so that they can take care of the preventative. We believe that if we can prevent diabetes, if we can prevent high cholesterol, it is cheaper to prevent it. And to that end, we provide that at 100%. It's free for our employees to have preventative care. We think that that's really important because it saves us in the long run. Our experience were that our employees and other healthcare industries employees that were not taking out insurance, which to me, I think if you start having those high dollar co-pays, 6,000, 3,000 people will not take the coverage and end up in the emergency department at any of the other facilities and perhaps will be uninsured and add more cost to that. But when we were doing that, we found that our organization, our employees are becoming more healthy because I think as healthcare providers, we should look healthy, we should be healthy as we're coaching people to take better control of their health. So I think the wellness initiative is really important, and I think that what we're doing shows that sustained effort, you can get the results without necessarily using a bigger stick. You can sweeten it with syrup or honey or something like that to get your employees to do.
That sounds fabulous, actually. And it sounds like what I'm hearing is, and I was trying to steer it toward Medicare. It seems like healthcare is healthcare, and if you deal with healthcare writ large, you will deal with some of these other things, Medicare and Medicaid. But what I'm hearing is a larger role for the individual, the skin in the game, flexibility for employers to do some of what you're doing. Not everybody can provide a hospital, obviously, but some flexibility. And it sounds like we need some regulatory clarity, and I'd like to work with any of you who want to help with that letter. I'd like to help do that. Dr. Thompson, I wanted to ask you, and I'll set it up by saying this. I have Blue Cross Blue Shield, and it is available to all federal employees. And I have the same health care that my employees have. contrary to popular opinion, Congress doesn't have special health care, although we have good health care. What interests me is I can be a marathon runner with a resting heart rate of 50, and I'm not. I will pay the same premium out of my check as if I was, 800 pounds, obese, smoking, what have you. Same amount, same exact amount. This is the federal government, and these are, I don't know how many are in the Federal Employee Health Benefit Program. It's a pretty successful program that has used market forces. It's the basis, for a premium support idea. And there's some market forces in there, but the federal government does not vary in what I pay. And it seems to me that doesn't make sense, and it's the federal government that ought to be leading on this. And I'm wondering, is this something the state has thought about? And your comments on that?
Well, I think much of the discussion around wellness is a culture shift that we need to go through. It's investing today in our health so we don't need the health care in the future. I've said publicly, if I could have everybody think about their health as much as they watch the stock market each day, half of our problems would be solved, because they'd be making an investment in probably what's even more important than their 401k about what their future is going to be like.
Sure.
But I do think, we have done some of the things 5-6 years ago through our state employees plan. We varied premium differentials by $25 a month. If the state employees didn't smoke, were moving towards a healthy weight and doing some physical activity. Now, $25 a month may not be enough to get dramatic behavior change, but for a state employee that's making $25,000 a year, $25 a month 5 years ago was pretty progressive. It was pretty assertive. The state can't get sued, so we didn't have some of the exposure that the employers had. But we've got to start aligning the financial incentives to get the outcomes that we want. I would say that that's both for the consumers of care, but it's even more important for the providers of care, because the business model in our healthcare system is set up to do more and more things that cost more and more dollars, whether the person needs it or not. And that's the business model. I'm not impugning our clinical providers. They want to do the right thing. But the right thing sometimes is coordinating that care and getting better outcomes, not doing one more procedure or one more test. And we've got to shift. It is a total culture change for the patients or consumers or customers or clients, whatever your term is. And it's a total system change for the provider, doctors, insurance companies, providers. Because the system that we've had, and it's been a system, our country chose employer-based health insurance, no other country uses it. Okay? It puts us at an economic disadvantage nationally, internationally, and locally. We're with it, we've got to make it work, but it's got to have the flexibility and the support to actually be successful.
I want to just say, before I move on and raise a few other points, if you find that implementing some of these changes are burdensome to you because of federal regulations or whatever, I would like to help in that. And as we talked about before, the reason healthcare is so incredibly important, it's not just because we're dealing with people's lives, it's not just because there are a lot of jobs here, but because we will never be able to deal with our budgetary problems, no matter what you do on the discretionary side, if we don't deal with that Medicare, Medicaid component. And you all know this, the numbers are the numbers. But if there's something I can do to help on that, please let me know. I really want to help on getting some clarification on the regs. I would like to throw out some ideas that we hear a lot about. I have been an advocate for some of them, but I'd like to throw them out and just get your take on them, and whether you think they would be effective in helping reduce cost. And I have heard from one person in particular who is not big on the idea of market forces or competition in the healthcare industry. And then I've heard from a lot of people who are. And one of those is tort reform. There's a Gallup survey that I saw in early 2010, I think of 700 physicians that indicated, based on the polling data, that about a quarter, up to a quarter of everything a physician does day to day is defensive to make sure they have litigation protection. That's a huge chunk. And when they translated that into cost, it was somewhere about a quarter. The president, in his State of the Union address, said that he thought we needed medical liability reform. I agree with him. We've been working on it in the Judiciary Committee, in the House Judiciary Committee, and whether we'll get agreement by the Senate and the president on it, we'll have to wait and see. But that's one that I'd like to throw out. Another one is competition across state lines for insurance, and I'm sure y'all have definite views on that. Ease of entry into the insurance market, and more competition the way we see with Geico and Progressive and State Farm and Farmers and all these different insurance companies that you see advertising and competing like crazy for your car insurance dollar, and even life insurance. I see a lot of that now these days on TV. There are several bills that, if passed, would allow for competition across state lines. And I know there's some difficulty of whose state rules do you use, and there's some that say, well, if they would require each state to respect the others, or what, sort of like a driver's license. If you've got one in Arkansas, they respect it in Texas most times. So that, I'll throw that out. I want to throw out the idea of insurance pooling, the idea that if there's a group of people, a natural group of people, whether it be a union or an association or a religious denomination, and they want to create an insurance pool, why don't we allow more flexibility there so that there's more freedom in that area, which might reduce costs. I know a lot of your views, pro or con, on physician-owned hospitals, and certainly welcome your thoughts on that. And then ambulatory surgical centers, where a lot of the outpatient stuff can be done at a cheaper rate. So I throw those out, and happy to go through them one by one, but also just happy to hear comments. Okay. How about, yeah?
Each of these are ideas that have been pushed around quite a bit. And as we discussed earlier, and I'm not going to rehash everything we just talked about, but utilization is a big key to cost. And which of these types of ideas may most affect utilization, I think would be the ones that have the best overall impact on cost. And I don't know the stats on those things, but having other options or grouping people together, I'm not sure how much those would help reduce cost. Maybe some, but I don't know if it'll drive down utilization. Perhaps tort reform, if 25% of all care is defensive in nature, so a physician's not concerned about being sued, then that could be something that I think would be very beneficial.
Is there anybody that doesn't think tort reform it will help? Is there anybody who just doesn't think it'll help?
Congressman,
Yes,
I don't think in and of itself it'll generate the kind of revenues to reduce cost, 17% of the gross domestic product.
Sure.
But it certainly will help, and it will help get a defensive practice of medicine. But I think the key is if you do it and tie it to clinical quality standards, because it's not just defensive medicine, it's are you practicing a standard of medicine. So I think it has to be tied to that.
Congressman, I would just add, the evidence when people look don't see the proportion of care as you report, but I can tell you from the practice of medicine, it's there. Okay, so I think we got to not inflate what we think we would get through tort reform, and I would also echo Mark's comments. We got to have some safety nets in place because we need some mechanism to actually identify the bad apples that every profession has. the other piece, though, and I think this forward-looking, I think the electronic health record system is going to be one of the most important tools for the clinical community to combat tort reform. And I would suggest that tort reform, just an idea, that there is tort protection offered to physicians, hospitals, others that are completely electronic. Because I think the medical errors that happen from pushing paper or not having information available or going back and time stamping something retrospectively that then when a lawyer gets hold of it is a flag. I think if you're electronic, you're not going to have the tort issues because there's a timestamp, electronic, everything's there. It won't be cheap to get there, but it's an added incentive for providers to adopt and to say, offer tort protection, tort reduction, whatever, to physicians, clinicians, hospitals that are fully electronic and completely in the 21st century.
That's an interesting idea. I don't think that's in the markup that we have now. I have not heard that, and I appreciate you mentioning that. Yeah, Dr. Ron, you want to?
Well, yeah, again, this is an area where we have to be really clear about what we're talking about because electronic health information is critically important in preventing gaps in care and reducing redundancies. But it's got to be a really interoperable electronic health information system that provides decision support so that you can assure that practice is occurring according to current standards and what is known to be best practice. There's a lot of gray in medicine, but there are also a lot of areas where it's really what the standard is pretty clear cut. And if in fact we have pervasive implementation of interoperable electronic health information that provides decision support, that can go a long way toward assuring uniform quality, and which then should provide a level of protection against lawsuits.
Yes, you're not.
You got to be really clear in what we're talking about.
You're making the distinction between some rudimentary electronic records and a system, that truly helps with diagnosis. And
we're not talking about me speaking into something and converting it to
You're not talking about scanning in a piece of paper.
We're not talking about a fax machine. We're talking about a real system.
And I toured your hospital and some of the system you have there and how you're monitoring through that process.
I just was going to comment.
Yeah, sure.
We fully support those systems and having them and using them in the same sort of decision support tools that Dr. Ron was describing. I think the other thing that's important to point out is that these systems are incredibly expensive. And if you want to talk about a really strong impact to our cost profile, these systems provide it. Doesn't mean we shouldn't do it, but we also can't get to the point where we don't have our costs covered, we're unable to deliver care, and at the same time we're not able to provide those systems because they are in the tens of millions of dollars to do them and do them well.
Are there, go ahead.
I would second that comment. How many rural community hospitals that we have decision-making or decision support software? I mean, it's zero. And when you're talking about the cost of those kind of systems and the effect that it will have on delivery of care in all of our rural communities, you have to take that in consideration. You have to provide time, and I think we've talked about that before. What is the timeline to do that? The support systems. In Arkansas, we have not super groups. We have 1 and 2 man groups in our state. So can you imagine the effect that it's going to have in our rural communities if we require an individual physician who has a private practice to have that type of software in his system? One, he doesn't have anybody in the office who could probably support it. 2, they have no idea how to get training or to use it, so it's not going to be effective for them. And 3, they can't afford the cost. So instead of staying in their rural community, they're going to come into, as we're urbanizing medicine, they're going to come into our metro areas and join either a super group or be employed by a hospital. And do we really want to have that effect on our communities? I'm a big advocate of a electronic medical record. We're a small hospital. We are implementing an electronic medical record. We've qualified for meaningful use for our first year. So I am a big advocate of it, but I think that you have to make sure that you take in consideration the effect that it's going to have on healthcare in rural states especially, And the time factor of allowing people to find systems they can afford, allow systems to catch up to small groups and hospitals, and to be able to implement it on a basis that it's not going to interfere with the delivery of care, which is exactly the opposite of what it could do for us.
Can I say something? On a flip side to that, we have a little clinic in Des Arc, Arkansas that opened 6 years ago, and it has a 6,000 patient population. Because of electronic medical record, we were able to make a difference in those people's lives in that area. We started with electronic medical record. We participated in chronic illness collaborative grants and those type things, and because of that, we studied cardiovascular disease, diabetes, and so forth, and got to goal levels in their cholesterol and their diabetes and so forth. So in 2 nurse practitioners and a physician in a rural area can utilize EMRs to make a difference and to follow national standards and guidelines. I'm here representing the Arkansas nurses, and by being a jobs conference, we have issues that nursing has issues with advanced practice, nursing issues, and issues in the state of Arkansas with Medicaid. And Dr. Ron and Dr. Thompson have sat and listened to me with this before at the health workforce, but we're fixing to have an added 200,000 people of the underinsured and uninsured into the Medicaid population in the state of Arkansas. Right now, advanced practice nurses can be primary care providers for Medicare. They can be primary care providers for Blue Cross Blue Shield and other private insurances, but we're not allowed to be PCPs for Medicaid patients. And it's a regulatory issue where we're not reimbursed for labs and technical components of x-rays and all those things. And what we need, what the nurses of Arkansas need, is to allow us to practice at the fullest scope of our practice. And when you're in Congress and when bills are coming forth that are coming forth for improving access to care, home health bills, there's a House bill out there now, 2267, that will allow advanced practice nurses to initiate home health care for their patients. Those bills are very important for us, for them to have neutral provider language. When we insert just the name of physician, it knocks out a whole population of primary care providers that need to be included in that, especially in rural Arkansas.
Great points, and I want to see how much time we got here. We got a little time. First of all, to close out on the medical records, so are there a variety of systems? I know that there are different software companies and what have you. Now, what you implemented in Des Arc, would that be of the quality that you're referring to?
Yeah, I agree with many of the comments on the electronic record. It is a change, and there is a decrease in productivity when you go through that change. There's a cost associated with it. My point was specific to your tort reform question, which I think when we're over the hump, I think having some recognition of clinical settings that are functioning in the 21st century as opposed to a paper-based 20th century model could help on the tort side. I think there are 2 pieces. One is it's the clinic setting, whatever that is, making sure that they're using electronic systems for patient support and access. It's also transferring. So when I leave my clinic and go to the specialist has it too. I'll give you just one example here where I think the tort issue will become real, tort protection. One of the stronger advocates for electronic systems, a physician up in Jonesboro, adopted electronic records 2 years ago. When I asked him publicly why, he said on any given day, for the patients coming to our clinic, our patients, we couldn't find 10% of their charts. Okay, that has to be contributing to medical treatment problems that leads to the tort. 10% in your own clinic for your own patients, you can't find their charts. That's the kind of protection I think you can say that never happens now. And I think that's the kind of protection that you could figure out how to, in the tort system, offer a carrot again and some support and some release of some of the restrictions that providers feel for defensive medicine.
I want to get back to what you mentioned in terms of unequal treatment between Medicare and Medicaid. So the federal government just has a different rule depending on whether it's Medicare or Medicaid.
Actually, the federal government recognizes advanced practice nurses as primary care providers. It's just the state of Arkansas that does not.
Okay, and so they leave that aspect of it to the state, okay. Do you want to comment on that? Just
I think the comment I would make is, and again, it's a system change. We're moving away from a cottage industry individual provider that sets a shingle out and operates on their own and kind of doesn't have any responsibility for being connected. We're moving toward a team-based approach where we need to use all providers at their maximum level of functionality and license so that we can reach the access points in the lowest cost. I've said before, I'm a pediatrician. I am the most expensive well baby care provider in the state of Arkansas. When a nurse practitioner can provide the same service per unit at a lower cost inside of a system that gets the same quality care, we're using the most expensive system to deliver care. And we've got to figure out how we use team-based care. Now, would I let the nurse practitioner, if I were king for a day, would I let the nurse practitioner be independent and doing her own thing? No, she needs a physician that when she's got a sick baby, it gets to the physician and it gets taken care of. So we need to move from a cottage industry, individual, independent, isolated practitioner model to a team-based model that has accountability, makes money, employs people to support that team, but that doesn't have the cost drivers in it that our system does right now.
And I appreciate a team base. I want a team base. I can't do anything without my physician. And I refer more patients to specialists than anybody in my system. And so I want the team base. What I want to just be able to do is be able to take that into rural areas and have physicians go out there with us. And right now it's difficult for us to go out there when we're tied to restraints.
and I'm sorry.
Well, I was just going to say, I think that that's an example of the structural changes that really have to be made in terms of how we deliver health care.
Right.
And that's where you start really affecting the outcomes and the costs and so forth. So those are tough questions, and it gets into people's turf and so forth. But
That's where we need to go.
That's where we need to
into
go.
turf.
And Congressman, just to add to that, technology is going to make the difference. You talked about electronic health records, but look at telemedicine. And if we have high-speed internet, high-ops, and the whole bit, I think we'll be able to proceed in working at the top of the license, but have new methods of how the supervision, if you will, or the oversight can be done. And I think telemedicine is going to help us with that as well.
And I'd be remiss if I didn't mention all the good that UAMS is doing with high-speed broadband. Also, this comes at a time when there are a number of different pressures on the number of physicians, and particularly in specialty areas, and even worse in rural areas. And so your point is a relevant one, particularly in light of where we're going, and your issue of getting the slots for your students and residents and what have you is directly related to this same supply issue. I mean, a lot of these issues are interrelated, and what I just want to reiterate is some of this stuff I can help with, and some of it I can't. But where I can, I want to be helpful, and I want you all to let me know. I think I gave you all my card with my cell phone, and so let me know I can help on this. And I think we've got, well, it's 11 o'clock. Thank you all so much. This has helped me immensely. I really enjoyed it, and maybe we can do something like this again. Thank you.
Thank you.